Okay, welcome everyone. This is Helena Hansen, Interim Chair of Psychiatry and Director of Semel Institute, wanting to welcome you to a very special Ground Rounds today uh, that is going to be presented by someone who I've had the pleasure of knowing for many years now. I think probably, 15, 20 years. First encountered our esteemed speaker when I was at New York University, an early career faculty member, and have kept in touch through the years and have gotten to know that he is an incredible champion for building our knowledge base and improving our approach to substance abuse disorders, and also mental health uh, across the board. A tireless advocate, really productive scholar. And I'll just give a little bit of a biographical background, which is that Dr. Wilson Compton is the Deputy Director of the National Institute on Drug Abuse. He is also someone who started off with his undergraduate education at Amherst College and then got his medical education and psychiatry training at Washington University in St. Louis. As I mentioned, he's a very prolific scholar, having authored over 250 publications. He was vice chair of the DSM-5 text revision manual and has led for NIDA development of the population assessment of tobacco and health study, jointly sponsored by NIDA and the U.S. Food and Drug Administration, with 45,971 participants. Wow, that must break a record. So Dr. Compton has received multiple awards, including the American Psychiatric Association's 2008 Senior Scholar Health Services Research Award, the American Psychopathological Association 2010 Paul Hoch Award, FDA awards for collaboration in 2012, 2013, and 2017, the Health and Human Services Secretary Awards for Meritorious Service in 2013, and Distinguished Service Award in 2015, 2018, and 2019. The list just goes on and on. I could go on all day with the awards that he's won. And in 2022, he became a Distinguished Life Fellow of the American Psychiatric Association. In 2024, he received the Health and Human Services Secretary's Distinguished Service Award for his work on the CMS, NIH, CDC, SAMHSA opioid policy data team, really a reflection of his ability to bring together important partners for national agendas. So with no further ado, thank you so much for joining us and speaking with us, Dr. Wilson Compton.
Well, thank you very much, Dr. Hansen. It's a pleasure to be with you. And as I was mentioning when we first logged on, we'd originally planned for me to do this in person when the American Psychiatric Association meeting was in Los Angeles just a few months ago. Unfortunately, my schedule got totally crammed that week. And so I'm really glad to be able to join you in two dimensions today, to share with you what I hope will be an inspiring set of ideas to inform research ideas and practice ideas that you and your colleagues at UCLA may have. I've prepared a pretty broad talk for you. And what I want to emphasize is that it begins with a little bit of background about me personally. And then we'll talk about some of the research that NIDA is supporting and talk towards the end about the research databases that NIDA has developed that could be wonderful sources for inspiration to you and your colleagues. First off, I wanted to highlight for you disclosures. There's really nothing related to this talk, but they're here for you. A little bit about me. As I mentioned, you all had asked me in preparing for this to talk a little bit about my own career, which is a bit unusual. I am by training and background and kind of disposition an academic psychiatrist. So most of my career started at Washington University first as a resident, but then as part of our residency program, we were all required to do research. And I figured I'd be going into private practice, but the research opportunity to work with Dr. John Helzer really proved inspirational to me. It reminded me how much I just love numbers and counting things. And frankly, that's what epidemiology is all about, is in many fancy ways using arithmetic and math to understand relationships. And that has been my inspiration. And I will say that in terms of how that developed from that initial paper and that initial work and inspiration from Dr. Helzer was our statistician went to work with a new faculty member at WashU, and so I was exposed to a new group on a regular basis. And I found and they started telling me about their work. Dr. Linda Kotler was launching a series of new studies at the time, and it really intrigued me. And she made room for me in their program of HIV prevention and population sciences. So I had a wonderful opportunity to work with Dr. Kotler, Dr. Lee Robbins, and many other luminaries in the psychiatric epidemiology field to help launch my career. It was really quite an inspiration. My themes across now what's been 35 years of a career include work that I hope has and will inspire policy and practice developments. So you've heard about my work on the DSM. A major theme has been tobacco regulation and tobacco policy, and we'll touch on that a little bit in my presentation, as well as overdose policy and practice. And so our work, of course, has been designed to address this major public health crisis that we faced in our country around the overdose issues in the United States. A broad theme has been training. And finally, as an official at the National Institute on Drug Use, my goal is always to help bring research opportunities to you and your colleagues across the country about where you can put your efforts in to have the biggest impact. So I'm going to talk to you a little bit towards the end of my talk about some research opportunities that NIDA has right now. Now, to start with, I thought we'd focus on the overdose crisis as both our major public health issue in the drug use disorder field, as well as something that has just garnered so much public attention. Now, many of us are very familiar with the last 20 years of the prescription opioids, heroin, and now fentanyl or synthetic opioids components of this. But I want to point out that this overdose crisis has actually been going on for more than 40 years. This curve represents, broadly speaking, an exponential growth curve over time. So it spans different substances, different populations, culminating in just devastating impact on the US population. Overall, for the last complete year of data collection in 23, there were over 100,000 deaths. And the vast majority of these involved opioids, particularly synthetic opioids that have been the scourge in so many parts of the US. Now, in keeping with the fact that even like the overdose crisis has changed over time, one of the things that intrigues me and keeps me occupied in the substance use area is that the substance use landscape is quite dynamic. You know, we've certainly seen an increase in methamphetamine use and methamphetamine related problems over the last 10 years or so across the entire country. This is not news in California. You all have had endemic methamphetamine issues for decades. But for the Midwest, the East Coast, and the Northeast, this is a relatively newer problem and one that has forced us to rethink how we approach substance use treatment. In the last few years, we started seeing contaminants in the opioid supply, xylazine, really surprising many of us. It's like, why is in and of itself, xylazine is not intoxicating or reinforcing. So why is it being added to the opioid drug supply? What is found beneficial by the drug sellers or the drug users of this animal tranquilizer that turns out to have some significant complications and side effects? Well, it's been increasing all across the country. And while it was at first in Puerto Rico and then the East Coast, particularly Philadelphia, was particularly hard hit, it's throughout the US at the present time. Well, as if those two issues weren't enough, it's important to keep in mind that the landscape is constantly changing. So I highlight for you where we see new agents appearing in different states across the country, or notice that these trends are at a low percentage level at the bottom, but we're seeing a market increase in medetomidine, for example, that may be taking the place of xylazine as the major contaminant of opioids seen. We've seen carfentanil as a particularly disturbing potential shift from fentanyl to an even more potent synthetic opioid. This is just an example to remind us that paying attention to what's going on with substances in your local area, in your community, in your district, or nationally is an essential part of developing a response to these issues. Now, the good news is the changes are not always so devastating. What you see here is just the graph that shows the overall overdose deaths over the last 10 years. And after a major peak in mid 23, we've seen a very sharp and a very gratifying decline over the last 15 months or so. And overall, this represents about a 25% decline in overdose deaths based on provisional data from CDC, but an overall decline of about a quarter, which is really a remarkable improvement. Now, if several years ago you told me that I would be celebrating that there are only 78,000 deaths from overdose in a 12-month period, I would have thought that was a remarkable statement. But when it comes down by this percentage and this amount over a relatively short period of time, it's really important for our field. We see this across all the different categories of substances. And so this represents a major accomplishment for public health and indeed for law enforcement. We're not sure what the causes of this decline are, and I would be very intrigued to hear from you all what your thoughts are and how you might approach to try to understand. Is it the naloxone that we've been distributing to so many communities? Is it the increase in medications for opioid use disorder that have certainly increased in distribution around the country? Is it changes in the drug supply? Is it, unfortunately, the fact that so many people have died that there are not as many people at risk for these most dreadful outcomes? All of these are distinct possibilities, and figuring out which ones are the most important is essential so that we can try to build on the progress and make sure it continues so we don't stop at 78,000 deaths per year, but continue this improvement. Now, when I think about what we've been doing as a country, and particularly with our research at NIDA, we're certainly focused on the immediate need for saving lives acutely in terms of the treatment of overdose. But in addition to saving a life acutely, we want to make sure that we help people turn their lives around in the long run. And that's where long-term recovery comes in and treatment comes in. And we'll talk a little bit about our efforts in both of these areas. We've seen a major emphasis on the distribution of naloxone and L-normophene, so the opioid overdose treatments over the last few years. I just highlight for you a really important announcement from the Surgeon General going back about 7 years. This has been a major enhancement to our public health armamentarium. I'm very proud that NIDA helped with research funding to support the development of the intranasal formulation of naloxone, which of course is the most widely distributed and represented a major breakthrough in terms of not a new chemical entity, but a way for it to be administered by virtually anybody, because anyone can use a nasal sprayer to put a medication in someone's nasal passages. There's a more limited number of people who can administer a syringe to take the injectable forms of naloxone and use them. So this has been a major change. In addition to saving lives acutely, as I highlighted for you, developing medications and increasing their use has been a major strategy and a goal for NIDA and for the federal government overall. We're very fortunate to have 3 major medications for opioid use disorder: the full agonist methadone, the partial agonist buprenorphine, and the full antagonist, a long-acting naltrexone. The key issue, though, is that while these can be very effective, they're vastly underutilized, both in terms of who initially gets access, perhaps more important, even though many people will start these medications, an awful lot of people drop out much earlier than would be beneficial for them in terms of the long-term recovery outcomes that we're all seeking. So what has NIDA been doing to try to improve addiction treatment in this space? Well, one area where our patients have been showing up is emergency departments. And I'm highlighting for you some work that goes back about a decade to show you where this has been going, and we'll talk about more research as well. But under the leadership of Gail D'Onofrio, she observed in their emergency departments that they essentially were the primary care doctors for many persons with opioid use disorder. And they kind of got tired of referring people to substance use disorder treatment and then having them come back, having relapsed or having never gone to treatment. So with a pivotal trial now 10 years ago, Dr. D'Onofrio demonstrated that by providing buprenorphine, she could enhance engagement and care, at least short term. Now, this was a major start, and we'll come back to this to show some long-term progress in this field as well. A second area where we certainly know our patients end up is in criminal justice settings. So we've had a long history at NIDA of emphasizing collaborations between health and justice to bring successful interventions and successful approaches for persons with substance use disorders. Some of this work is represented by studies like Dr. Josh Lee's study, showing that by providing extended release naltrexone, the injectable monthly injection, that they could improve the outcomes of persons who were already on probation for their as part of criminal justice system. So even those with the most significant sanctions and supervision benefited from medications. That's just one example of our work to enhance treatment for criminal justice involved individuals. Another area where NIDA has played a particular role is in head-to-head comparison of medications. It's unusual for the pharmaceutical industry to subject their medications to comparisons among different products. They mostly want to compare it to placebo or no treatment to show that the effectiveness of their medications. But a key question was buprenorphine or extended release naltrexone more effective? And it was quite clear in a major head-to-head trial that overall buprenorphine is more effective. But when you look at that graph, there's something very interesting there, which is the difficulty with naltrexone, with the extended release naltrexone, is you have to be off all opioids in order to start this opioid antagonist. We can't give you a long-acting opioid blocking agent when it's going to put you in protracted and significant opioid withdrawal. So the difficulty is helping people achieve that approximately 10 days or 2 weeks of full abstinence in order to qualify for use of the extended release naltrexone. For those that where it was administered, the outcomes appear quite reasonably similar. But it's that initial difficulty of access and getting people engaged in naltrexone treatment that seems to explain some of the differences. All right, these are just some of the long-term ways and earlier ways that we've been approaching improving addiction treatment. But I'm really pleased to share with you results of a study that came out just a few months ago, demonstrating that you in California have been at the forefront of increasing emergency clinician buprenorphine initiation. The rates went from essentially non-existent in 2017 to about 5% in the most recent data from 22 in this trial. This is based on efforts from your state officials, but more important, it really represents a culture shift in your emergency departments where they see themselves as being able to provide long-term initiation of treatment that we hope will have a long-term impact on patient outcomes. So our question now is, can we take the California example and begin to export this across the rest of the country? A really important question that involves practice change and quality improvement approaches. Now, while we're very pleased with having overdose remedies like naloxone and nalmefene, we've certainly continued to develop new approaches, whether these may be antibody approaches that can serve as sequestrants that will keep opioids, in this case, fentanyl, in the circulation and out of the brain, where it will have the devastating effects by reducing respiration and causing death. There are other forms of sequestrants that are being developed that will keep medications in circulation and out of the central nervous system as a way of improving the outcomes. These are one of the ways that we're approaching the overdose area. When it comes to treatment, of course, I have a number of things I can talk about, but I want to share with you the entire field's excitement around the potential application of GLP-1 receptor agonists. These are the Ozempics of the world for treating substance use disorder. What makes this so fascinating is that the data from electronic health records from primarily observational studies has been that it appears that those that receive these medications have much better outcome when it comes to tobacco use, when it comes to alcohol use, when it comes to opioid use, when it comes to stimulant use, when it comes to cannabis, across the full range of substances. Now, this observational data needs to be followed up with full clinical trials to demonstrate the efficacy in addition to this broad-based effectiveness. but it certainly has many of us quite excited because it appears these agonists maybe get at something that is in the underlying issue related to addiction writ large. So the broad basis for the overlap among all the different substance use disorders is being addressed potentially by this new medication. Please stay tuned. You'll be hearing more about this in recent months and years, and I certainly hope it's as successful as we want it to be, and certainly we will be learning a lot about whether it is successful or not based on ensuing research. In addition to this new medications, I'd also highlight for you the importance of brain stimulation as an approach. I think about these as personalizing intervention. We're taking advantage of an understanding of the brain circuits that are involved in the addiction cycle and using non-invasive techniques like TMS or direct stimulation or ultrasound, or sometimes even invasive neuromodulation like deep brain stimulation or potentially high intensity ultrasound as targets for a brain circuit or personalized intervention. Now, that's just a quick snapshot of a much broader portfolio of medication and treatment development. But the other major area that I want to highlight for you would be our implementation or population science approaches to improving outcomes. Now, I've only highlighted some of these in terms of emergency department practice changes, but some new ways that we've been supporting this have been with many research studies supported in our NIDA clinical trials network, including a number that have been implemented by your colleagues at UCLA through their collaborations with the CTN program. A major program called Justice Community Overdose Innovation Network that's bringing new practices to all aspects of justice-involved persons, whether that's those on probation, parole, and particularly those who are incarcerated, to make sure that treatment is available both while they're incarcerated as well as when they are released back to the community and have extraordinary risk both for relapse and overdose deaths during those first few weeks of reentry. And finally, a major study has been our Healing Community study that was deploying evidence-based interventions tailored to communities to address what happens when you put the packages together of overdose remedies and medication treatment and communication outreach. How do these work together and what are the best combinations of these? These are the kind of implementation science or effectiveness trials that are really going to inform practice and policy in the near future, we hope. While we've been building our treatment and our early intervention for overdose remedies, I also want to highlight a new area of focus for the National Institute on Drug Abuse, which would be recovery science. This is, of course, not a brand new idea for any of us, but to emphasize it in terms of new research networks for the study of recovery is an important development at NIDA. And I'll even point out that our services research branch has recently been named the Treatment Services and Recovery Research Branch to emphasize the importance of long-term recovery in terms of our thinking and kind of putting into practice the idea that these are chronic relapsing conditions and recovery is a process and not a destination. I'm going to step back. We've talked about treatment. I've emphasized recovery as a new theme. I also want to just end this initial foray, and then we're going to shift gears a little bit by making sure that I touch on prevention. We, of course, have been focusing on treatment as a way to address the difficulties that communities and that individuals face. But if we avoid this by building strong individuals and by helping individuals develop the resilience to avoid these outcomes, we can save individuals a whole host of complications, and we can help our communities be stronger in many, many ways. Our work includes multiple intervention strategies that have been developed over now decades to decrease risk, whether these are individual or group-based or high-risk individual-based interventions to address the risk factors for onset of substance use, or enhancing resilience factors or protective factors. These would be the two components of intervention, of prevention science that our work has been promoting. I will say that one of the issues in prevention has been our lack of a full infrastructure for supporting prevention across the country. And that's been the source of new research and new sort of systems level approaches that our research program is moving into. Okay, I've highlighted for you, I hope, two major themes. One has been how my journey through research, moving from an academic position to a new position in government, which it's no longer new. I've been doing this for 20 some years, but it's been an opportunity to take what I learned in academics and extend them out to a broader audience, as well as focusing on how the overdose crisis has led to a number of major programs and some successes from our research at NIDA. But I want to shift gears and talk to you all about comorbidity. You all are very aware that comorbidities are the rule, not the exception. So if you have one psychiatric disorder, your chances of having multiple are markedly increased. This is certainly true when it comes to substances and the vast majority of psychiatric disorders. They cluster in meaningful and known ways. Even when we look at those who have bona fide more than one diagnosis in broad population surveys, this is results just coming out last month from SAMHSA's National Survey on Drug Use and Health. We see that there's some 8% of the adult population that have a combination of at least one substance use disorder and a mental illness. A slightly smaller number, but still something like 5 or 6% who have serious mental illness. And when we look at the combination of substance disorder and major depression among youth, we see about 3% having a combination of major depressive disorder and substance use disorder. So even in the 12 to 17-year-olds, having that combination is not so rare. Well, what may explain this? How can we understand it? And where's our research shedding light on this? Some of the way we understand this is by looking at the developmental trajectories for substance use disorders and for many, not all, but many psychiatric disorders, where I would say adolescence is the major period of risk for the onset of substance use disorders. And for many of the psychiatric conditions, for instance, major depression, psychotic disorders, bipolar disorder, typically have their main expression either late adolescence or young adult life. And so what is it about brain development during this period that can help explain it? These are major areas of research, and these overlaps give us clues about where to look for the mechanism that explains these. I've been very excited to see our genetics program help us understand not just that these things run in families, that there's a strong heritable component, but beginning to understand, well, what are the specific genes involved in the risk for substance use disorder and other psychiatric disorders? With Hatum's study that came out now 2 years ago, there was really a demonstration that the genetics are common across all substance use disorders. So the vast majority of genetic risk is a general risk for substance use disorder. Of course, there is some specific risk for cannabis use disorder, for tobacco use disorder, for opioid use disorder, for stimulant use disorder. But the majority of that genetic risk would cut across those different categories. I think this makes me this is part of the reason I'm so excited about GLP-1 agonists, because maybe for the first time we're seeing something that pulls together what we've had as an understanding of the overlap of conditions, even with some of the genetic understanding of them, and now potentially with treatment. These are some of the advances that I hope you and other colleagues will help us build on for the future. Now, I've had the pleasure of working with colleagues looking at large population data sets. And we explored the National Survey on Drug Use and Health to address what had been a vexing issue in the tobacco field, for example. So we became interested in how tobacco use disorder and other mental illnesses overlap. It's well known that persons with psychiatric conditions smoke more cigarettes than persons without those conditions. In fact, up until recently, it had been sort of common knowledge or common thinking that the improvements in tobacco use, which have been extraordinary in our country, have been limited to those without substance use disorder, limited to those without mental illness. Well, we looked at this question with data from the large-scale National Survey on Drug Use and Health, and we actually found that that wasn't exactly true. We see improvements in terms of reduced use of cigarettes, reduced cigarette smoking in the past month for those with major depressive episode and those without, for those with substance use disorder and those without. Notice that the rates are higher for those with substance use disorder or major depression as expected, but the improvements have been very important over the last decade. And so I think this gives us hope that we need to continue to bring treatment to our patients who have psychiatric and substance use disorders. I'm going to come back to this with some even more recent data in just a moment. When we did that work on major depression, Dr. Volkoff challenged me and some colleagues to say, well, how about persons with schizophrenia or broad-based psychotic disorders in general? Well, the literature was quite clear that tobacco use, in this case, particularly smoking, is much more common in persons with serious mental illness than in others. And that's well known to those of us that have treated patients with schizophrenia or other long-term chronic relapsing psychotic disorders. Uh, but we didn't have very much national data on this. So we were able to use our population assessment of tobacco and health study. And indeed, we showed that all the different tobacco products are more common in those who self-report psychosis. Uh, and so that wasn't too much of a surprise, but that was an important part of our project. But to me, what was much more hopeful I think a more impactful finding was that people with psychotic disorders were very likely to make quit attempts. In fact, even more likely than the rest of the population to make quit attempts. They used various approaches to help them quit. And so the fact that they're continuing to use means that it's not for lack of trying it. So it gives me the extra motivation to bring new treatments to persons who struggle with quitting smoking and trying to develop new approaches and more effective approaches for our patients with psychotic disorder. Now, another aspect of thinking about the overlap of substances with particularly psychotic disorder has been this concern about, is cannabis causing some of the psychotic conditions? And there's been quite a bit of work on this. It certainly is a risk factor. The question is, how much might it explain in terms of populations? We were very intrigued by some work that our colleague in Denmark conducted a few years ago, showing an increase in the incidence of schizophrenia corresponding to an increase in cannabis use disorder. Well, we worked with that team to look at differences between men and women, or in this case, boys and girls, because they were mostly young when they were using cannabis, starting cannabis use. And based on this large-scale Danish data set, up to 30% of the population attributable risk for schizophrenia in young men was explained by increases in cannabis use. So indeed, this represents a potential important target for prevention and intervention. To build on this study, and we're going to go to the ABCD study next, there's been some really important early work to show that even prenatal cannabis exposure may increase. In this case, it wasn't full psychotic disorder because the participants in the study are not old enough to have expressed this very serious condition for the most part. But they are seeing an association of even prenatal cannabis exposure with psychosis proneness among children in that study. Now, the sample size is fairly small for this children, but ABCD study is a landmark project with some 12,000 children that was started around age 9 and 10. Now the youth are in their mid-teens and will be followed, we expect, at least until their early 20s to get them through the major period of risk for the onset of both substance use disorders and many psychiatric conditions. UCLA has been part of this, as have been sites all around the country. And I'll just highlight for you a few of the findings. The landmark findings are remarkable from this program of work. One that really intrigued me was the lead exposure and cognition and brain. And it's quite clear that lead exposure is not good for brain development and for brain structure and function. And but there's an interesting association and a interaction with socioeconomic status. So across each of these graphs, you see increasing lead exposure. So the increasing chance of exposure based on location of the respondents in this large scale study. What you see in the three different groups, though, are high income in blue, middle income in the open dark circles and the orange circles are low income. What you see is that those who are of high income are able to buffer the risk. They may change their lead exposure. Just think about people's ability to change their water pipes, to repaint their house in a safe way, to not have lead exposure in the environment. But what we see is that those in low income areas are not able to buffer these effects. So something that I sort of think of as a problem from 30, 40 years ago remains an issue in the US and is amenable to intervention and addressing this serious issue for brain development. We've certainly been very pleased that ABCD is just now, as the youth, they're reaching an age where they're beginning to use substances. We can begin to see the variation in neuroanatomical pre-existing risk factors for the onset of substance use. Now, while this is beginning to be apparent for substance use, we're also seeing this as a general biomarkers for risk of all mental disorders. And so the overlap among them may show shared risk across different regions as well as specific risk for whether that's a risk for anxiety disorders or depressive disorders or eventually for psychotic disorders. Interestingly, we've seen some really nice work now reminding us that sleep disturbances may be one of the most important risk factors related to the onset of multiple mental health conditions. We've also seen some very nice work from this group just published in Nature Medicine, suggesting that symptom-based scales like the CBCL may be more effective in terms of predicting the onset of mental health risk a year later. So ABCD is helping us both with methods development as well as the major contributions. The impacts have been extraordinary for ABCD. The data has been used in more than 250 successful grant applications. The publications by ABCD of data from ABCD is extraordinary. We're seeing that these publications not only are large in number, but they've had a big impact on policy. For instance, over 16 that have had an impact on clinical guidance, some legal documents, and working papers and blog posts. So many ways beyond sort of our traditional academic measures for this high, really landmark project, the Adolescent Brain Cognitive Development Study. Building on the success of ABCD is our HBCD, or Healthy Brain and Child Development Study. This is a similar longitudinal project, which is in the process of being fielded right now, but it's trying to fill in the gaps. While we know that adolescence is the major period of risk factors for substance use start much earlier. And so understanding how brains develop in response to various risk environments and risk situations and risk factors across time is a very important undertaking and will lead to the kind of sort of major impact findings that we've seen from ABCD. This study already has been successful in recruiting more than half of their sample. Our interest immediately are in substance exposed, prenatally substance exposed individuals. What about their brain development and how will that proceed? So we see more than a third of the sample have some substance use exposure. And that's speaks to the tremendous work that the group launching this study has been successful in doing. The third and final project I'm going to mention to you is the PATH study. This is one that I personally have been involved in since day one to help launch it. Back in 2011 is when we started the the request for contracts to start this project. This is a large-scale longitudinal study. It actually is a mixed method. It has multiple approaches. Not only do we have a single cohort that we're following over time, we keep adding new 12-year-olds. The idea is for it both to have cross-sectional validity as well as there's a tremendous interest in the onset of tobacco use. So you need persons who are young to understand the first uptake. So we have continued to replenish our 12-year-olds, and at times the entire sample gets replenished. Over now, it's been a 12-year process of support from primarily the FDA Center for Tobacco Products, but multiple NIH institutes. This is another landmark study that's had more than 1,000 publications so far. We've seen many impacts on policy. It's cited in rulemaking related to tobacco, the Surgeon General's advisory, congressional testimony, and multiple of the tobacco product applications where some of the reduced risk products are presented to FDA for their consideration. Now, one of our newest PATH papers that was just released 6 days ago today was published in JAMA Psychiatry last Wednesday, looked at within individual change across waves. So our goal was to look at what's the relationship of smoking status with substance use disorder recovery status. So we looked at individuals who had a change in their recovery status. Either they went from not using to relapsing or using heavily. They had to have significant substance use problems to begin with, because you can't be in recovery if you didn't have a problem. So it looked at those who had problems and then tracked them over time. And those who changed status were informative to help us understand what is the relationship to smoking status. And it turns out that recovery from smoking, quitting smoking, led to about depending on whether it was the full model or a more limited adjusted model, 30 to 40% improvement in their substance use recovery status. So they are 40% more likely to be in recovery if they had quit smoking. So to my mind, this really encourages drug treatment programs to consider enhancing their smoking cessation implementation. There's sort of two reasons for this. One, I already know that quitting smoking is good for your health. So from both an individual and a population health perspective, we need everyone to help people quit smoking. But the extra motivation, if my program is particularly focused on cocaine use disorder or opioid use disorder or cannabis use disorder, is my primary outcomes may also be increased if I help my patients quit smoking. That hasn't always been accepted by the field, but this data at least suggests that. Remember, these are associations, and so there could be common factors that explain both outcomes. But because it's within individual change, and we did lagged analyses as well as the direct approach, it's a reasonably strong evidence for this association. And so with that, I hope I've highlighted for you how our research can help inform practice and policy, whether that is the ABCD study, the HBCD study, the PATH study, or many other aspects of the NIDA portfolio. Our development of intranasal naloxone and how that's led to almost innumerable saving of lives. We actually just saw last month that some 1.8 million persons across the US report having received naloxone or another overdose intervention in the past year. That is a lot of people whose lives are potentially saved by these medications. Now, I would highlight for you that substance use shows remarkable dynamism regarding ongoing surveillance and creativity. That's a major theme. Frankly, that's one of the things that keeps me engaged in this field, is that it's not stable and static, but keeps me on my toes intellectually and keeps my brain moving in multiple directions. There are many new tools and targets from both basic science, translation science, epidemiology, and others that show promise in uncovering causes and developing new approaches. Our prevention science is absolutely essential in developing strategies to address in environmental underlying risk factors. And finally, delivering health services is absolutely essential. Now, I'm going to end just with a word cloud of all the different people I've written papers with over the years, because to me, these are my colleagues who have allowed me to be successful and really to enrich every day of my work. It's both a professional journey and a personal one to work with all these wonderful people and to, I hope, have an impact on the populations that I care so much about and want to help improve. And with that, let me wrap up, and I left a little time for questions. Thank you very much.
Oh, thank you so much. That's such an inspiring talk. And I see there are already a couple of questions in the Q&A, so I'm going to take them in order, but others that have questions, please do feel free to post them on the Q&A tab. So the first question is, most community treatment is behavioral. Can you talk some more about the degree to which NIDA is working to develop new evidence-based treatments and improving existing evidence-based treatments and prevention?
Well, one of the key stumbling blocks and complications has been, for instance, we have wonderful interventions that are useful for stimulant use disorder. NIDA research was pivotal in understanding that contingency management and a variety of variations around contingency management can be effective and are effective in addressing stimulant use disorder and, frankly, almost every other behavioral condition that we've applied them to. The issue has been the implementation of these has faced major stumbling blocks.
Mhm.
It is less an issue around additional knowledge needed about this, but more willingness of regulators and others to allow the implementation. The kind
Mhm.
of the stumbling block has been if you tell people I'm giving you money to quit using substances, people say, "Oh, you're just paying people who have a bad habit."
Yeah.
Or bad behavior. And that has just really made it impossible outside of research in some very limited ways to see expansion. I think the reminder that we see incentives used every day, every one of us are influenced by incentives to shape our behavior. And contingencies may be a direct way and can be done in a systematic approach to shape it in pro social, positive ways. We're fortunate that there was a change. And so just in the last year, we've seen some change in the guidelines coming out of the federal government to allow SAMHSA to, at least for public treatment programs and that use their money, to use a much more reasonable amount of overall rewards in contingency management, up to I believe it's 650. It might be 750. Don't quote me on the exact amount, but it is at least an amount. Previously, they had allowed up to $50 worth, which is nowhere near enough to produce behavior change over time. But the amounts now allowed, when it's properly implemented, look like they'll be effective. You've got the opportunity in California because of your leadership in the Medicaid waivers that allowed contingency management to be implemented in California in your Medicaid funded programs to help us understand how well this works. When does it backfire? What kind of implementation needs to be included in the treatment programs to make sure it's done correctly and well? Because while contingency management can be successful, you actually have to do it following the behavioral principles. That's just one example. We have one of the issues around behavior treatments has been we don't always have the infrastructure to implement them. So we're
Mhm.
very keen to understand what can be the broad-based infrastructure to bring behavioral treatments into widespread use. This has been a thorny issue for not only drug treatment, but also drug abuse prevention, where we have some very effective drug prevention that are all behaviorally focused and all either community delivered or school delivered, but some kind of behavioral intervention. And yet developing a system of care to implement these widely and systematically across the country has been lacking in the US. We're open for your best ideas in this space.
So well put. I have questions on that too, but I'm going to first go to the other two questions that were posted. So there's a question about data supporting the positive impact of religious spiritual involvement in reducing deaths of despair, including from substance use. Does NIDA partner and or work with religious and or 12-step groups to help support recovery from substance use disorders?
Absolutely. If you're interested in learning what our research portfolio in this space is, I encourage you to look at the NIH Reporter, where you can readily search the entire NIH research portfolio and look up to see how many studies NIDA has or other institutes may have on either religiosity or formal participation in religious organizations can have in terms of health outcomes. We've also seen these be very important vehicles for the delivery of services. There are
Mhm.
many hidden populations that are hard to reach, and yet they may attend religious services. And so, can we use those congregation approaches as a way to reach people who may be at risk? I certainly had experience of this being implemented during the COVID pandemic and was really excited to see how many religious groups came together, and there were research projects to help understand both when this worked and when it wasn't more effective than other approaches. Because just because it seems like a good idea. Not all of our good ideas work in practice.
That's so well put. And as someone who wrote her anthropology PhD dissertation on faith-based treatment for addiction in Puerto Rican ministries, and got some NIDA support for that, I can vouch for the real openness of NIDA to understanding community-based approaches and interventions. And my colleague Ayana Jordan, for example, got major funding to actually do clinical trials of church-based recovery support and treatment interventions. So kudos to NIDA for a very broad-based approach. And then there is a question here, Larissa Mooney, what are research gaps and priorities in substance use disorder prevention or early intervention strategies in youth and young adults?
There are numerous gaps. I would encourage you all to reach out to Amy Goldstein, who runs our prevention research branch, and ask her that question, Dr. Mooney. But I would point out to you that while, at least from our portfolio's perspective, we have had a great deal of development at kind of middle school interventions. There's a lot of interventions that can be effective in reaching those at risk prior to the major onset of substance use. Some early childhood interventions that look extremely strong to my eye. We haven't seen them implemented as widely, but we've seen some of those be developed. A gap area is that while we think of childhood and early adolescence as the place for prevention, a lot of substance use starts or accelerates during late adolescence and early adult life. And we have not had as much focus on the sort of, I don't just mean college, but college age and early adult period. So that is one where I would say we need some real help. I also think we've seen a marked increase in substance use by an aging baby boomer population. Some of that is a resumption of old habits or people bringing their habits with them in ways that we didn't experience in elderly groups before. But there may be some new onset and room for prevention there that we have almost no work in that space. Those as major gap areas that I would highlight for you just off the top of my head.
Thank you so much. We also have a question about the end of 2023 decline of overdose deaths, and a question about whether aspects like or features like border control, cultural education could have been related to that. I'm inferring that from the question. Could any prenatal or postnatal use of any substance lead to risk? Okay, that sounds like a separate question. So
There's two questions there.
yeah, the first question is, some of the factors you would point to in the decline of overdose deaths starting in 2023. And then the second question appears to be a separate one about prenatal and postnatal use of substances leading to risk, despite some doctors or parents saying that beer during breastfeeding is okay. So I want to take it in either order.
Well, let's start with the first one around what explains the decline in overdose deaths. And I went over that very quickly. While we certainly know that we have saved lives acutely with naloxone, that provision over the long haul of medication for opioid use disorder can reduce deaths. So those are major ways that deaths can be averted. But we've also seen some indication of shifts in the drug supply. Looking at drug testing of confiscated tablets and medications, we've seen a lower level of fentanyl in those. This has been a notorious issue over the last like 6 or 7 years, where if you get pills and they aren't coming from your local pharmacy directly, they have a very high likelihood of being, no matter what they look like, they have a high likelihood of being contaminated with synthetic opioids. And because the amounts are so unpredictable, they can be easily lethal. We've also seen the drug supply in community-based testing either level out or decline a little bit in many parts of, not all, but in some parts of the country. And so the drug supply may be shifting, and that may explain some of it. I also think there's a learning process in that you all in California were late to the fentanyl epidemic. And every time the drug market shifted from a predominant heroin to a fentanyl market, you saw an explosion of overdose deaths. We saw those in the East and the Midwest earlier. You all were in the around 2020 to 2021 when the drug markets really shifted in the western part of the US. We think that's because the drug sales distribution networks are regional in that way. And that's all I can say is that's about as much as I know. If you or colleagues have researchers that can help us look at this intersection of drug distribution and the drug markets with individual behavior, that would be very important. But drug users have learned too, they don't want to die. And so
Mhm.
they're learning to not use by themselves, to have somebody there with naloxone available, to to get help or to support people when they may have overdosed much more readily. I think that certainly had some impact. And I don't know which one is the most important of all those. We need your help to figure it out.
Yeah, that's really well said. I will say that my anthropology colleagues have been on the ground doing field work to provide explanations. So during the crack epidemic, anthropology colleagues came up with the concept of community learning to explain how it is. I think what you were just describing as a form of community learning, right? That people do pass on information and change their behaviors to protect
Absolutely.
themselves. Um, and
The
then
last
with
question
regard to,
about prenatal or postnatal substance use, please
yes.
talk to your OBGYN colleagues and find out what the most current recommendations are. The easy answer is none of that is safe. And so living a clean, organic product only approach to life might be your best approach. But realistically, helping people minimize their risk and live the lives that they want to do and use the substances or products that they choose to use in the safest possible way requires us to understand the specific risks. I certainly know that many substances are transmitted through breast milk, so that would be a concern. I, I can't speak personally about the specific risk of alcohol and breastfeeding, and I'm going to go learn when I get done with this presentation. I'll call some of my colleagues at NIAAA to help me understand. But you all can figure that out too.
This has been such an enlightening and inspiring talk. Thank you so much, Dr. Compton, for joining us. And we'll be taking the call to action and the call for partnerships and collaborations to heart moving forward. So thank you so much for
Well, it's
joining.
my pleasure to join, and thank you very much for this opportunity to share some of what I'm doing and what we're doing at NIDA with you.
Thank you.
Bye-bye.
Bye-bye.